Gloria Johnson, Shirley Young. People are coming. Hello? They're muted. Well, don't look like we're going to be able to have the meeting like we thought. Okay, come on, I'm waiting for you. There are people in the room. Don't turn that chair back around. So no, turn it back toward there. Yes. Thank you. Gloria, can you hear me? Gloria, can you hear me?
Meeting started at 12:30, that's why.
I know. Probably was telling them wait for host to start meeting. Her video's off, but her microphone is on. See, this is how you're going to call them. She's going to call the names of people. I don't even know if Gloria wants to show her video. This is going to be like a chocolate game.
The recording started already?
It has to. If I don't start it, then the meeting won't start. It has to stay on.
Testing 1 2, testing 1 2.
Hello.
Hi. We're actually both in the middle of Zoom meetings, so I'm just trying to test, make sure my mother's okay, and she'll be joining she'll be joining via video just shortly.
Okay. Thank you. Hello, Dr. Porter.
There he is.
Hi.
Always on time.
Love your bow tie. Oh, no. Oh, I got to admit, people. We're going to keep it. Honey, listen, people are in. They coming in to get seated.
Oh,
okay. Yeah. The speakers are going to stay unmuted. Everybody else is going to stay muted for now.
Okay. Yeah, I put the bow tie because I didn't know if I still knew how to tie it. I haven't worn it in about 3 months.
Wow.
Looks good. It looks natural. It looks natural.
I need Robin in here so she can admit these guests.
I'm going to run and go get my phone stands.
It is off. I was trying to call Robin, but I have no way of doing it. It's off the hook. It's back there off the hook. Yeah. Hello. How's everybody? Good. It's so good to see you. Oh, hi, Sheila. Hi, Emmett. I'll unmute him for a minute.
Can you hear me now?
Yeah, I can hear you. We're going to be
Yeah.
we're going to be muting everybody because of it's so hard for people not to talk over each other and all of that, but we'll let you know. We're going to have everybody muted except for the speakers, but you'll be unmuted for the Q&A. So we're ready for that.
There's Lee.
You guys, everybody looks wonderful. So glad to see you. I need to do this. I need them badly. Where are they? Let me tell them. Here we go. Okay, they're coming in.
Move right along.
Yep. I got to play the juggler here. Everybody's there. We still got a lot of folks to come. Get you placed up there. Everybody looks so good. It's so good to see everybody. It sure is. My God.
I hate we can't be in person.
Yeah.
Yeah, but this is an awesome platform, and I'm so grateful that you were able to put it together.
We're thankful to all of you, every one of you for this.
North, south, east, and west.
From around the country. We're gonna party today.
We're gonna get you global soon.
Oh wow. Yeah, we're going to be muting everybody, just so you know. We're going to be muting everyone so that the background noises in different people's houses are not going to disturb others in the meeting. Doris, are you there? Okay, here
Can
you
you hear me?
Yeah, I need to get you the co-host here.
Okay.
There you go. Okay, that's it. Soon as Robin and I'll do her too.
Okay. So you want me to start letting people in?
Yeah, let everybody in.
Okay.
Noises that we have to pull out here. She's letting them in. Hi.
Hi, so good to see you, Kat. I saw this. I said, oh,
So good to see all of you.
Alert from messages. Your message could not be sent.
What was that?
Somebody sent a message that can't be sent.
No, that was my personal iMessenger. I was trying to send a message to Robin, but that's okay. She'll be in here in a minute. I just needed some help admitting folks.
Yeah, I got you.
Okay, now I got to put it back on, Faline. Okay.
Good afternoon, Dr. Brown.
Hi, how are you?
Good, it's good to see you.
Oh, I've been hearing these great things that's happening.
Hopefully we can catch up over coffee soon.
Yes.
Virtual coffee.
Yeah, virtual coffee. Otherwise, we'll have to have distancing and massing, all of that stuff. Yes, but I'm glad things are going well for you.
Thank you. Thank you so much.
It can't be sent because my mobile isn't on. I have to unlock it here. I'm going to have to turn on. Yeah, he did. I got to send a link.
Hello and welcome, everyone.
Hi, this is Virginia. Of course, you can't see me because my camera doesn't work.
Oh.
Okay, but we can hear you.
Good. All right. I'm going to go back to mute.
It's still ahead of the time. It's sort of like when you guys go to one of the luncheons or dinners, we're waiting for the guests to come in.
Hi, I'm Wanda Lipscomb Anderson
Hello.
from KAC.
Oh, wonderful. You're one of Virginia's folks. So good to see you. We're going to be muting everybody for all various noises that are coming.
Hi, I'm Kwana Scruggs.
Hi, Kwana. Thank you for joining us.
Okay, now I turn it off now, right?
Yeah. Yeah.
Hey, Sawana, this is Jenny. That's another KAC person.
Okay.
Okay. I don't know how to turn off the mute.
Just click that microphone until the red X goes through it.
Okay, I see it now.
Yeah.
I have did this before, believe it or not, but
that's okay. We're going to tell you all about how to do this. Hi, Wolfram. Hi, Bruni. Oh my God. Where's Robin? Aaron. Hey, Aaron. Hi, Jeannie. Hi, Angelo.
This is Gloria.
Hi, Gloria. How are you?
Hi, Gloria. That's our sister.
Hello. So you want us to mute? Do we need to mute now?
Yeah, we're going to mute in just a few minutes. We're waiting for our technical person to come in. And then you guys will all be muted. We have a mute everybody except for the speakers. And then they will let you in for Q&A, for questions and answers.
Okay.
It's a lot of people still in line here, so we're letting them in. Lots of folks. Wow, good crowd. Okay, I think we're going to go ahead and get started. There's the other person I'm looking for.
Okay.
I'm looking for Robin. You see her? Not quite in yet.
I don't know why Robin is saying waiting.
Yeah, she is. I've let her in.
Yeah.
Okay, guys, this is going to be a lot of fun. Here we go. We've got over 100 people. So if you keep hearing those buzzes, we're just letting people in. There's Dr. Ali. There's Pastor Sims. Hi. Okay, I think we may need to get started. I'll let folks in. Ed is going to start this program off. And so, and then Doris. Where's Robin? Robin's still joining us.
She's still joining. Understand why that's taking work. I think she's in now.
Okay, is she? Okay, where is she? Let's see.
Yes, make her.
Yeah. Oh, this is incredible, guys. You guys are something else. Oh, here, Robin Kelly.
Is in, but she doesn't have a phone or a visual. I don't understand.
I don't either. Okay, Doris, it's on us for now.
I'll
keep an eye on it. Let's get this started.
Yes.
Go ahead.
I'm ready.
Okay. Okay, we're going to mute everybody. Hold on. Okay, I need to. Can everybody hear us? Okay, good.
Yes, ma'am.
Okay, Doris, I need you to unmute.
I'm good.
Okay. Okay, go ahead and start.
Hello, I'm Ed Sanders, president and co-founder of 50 Hoops. I want to welcome you to the 50 Hoops Mobile Cancer Conferences and Workshops, otherwise known as MCCaW. First, we want to thank our sponsors, Genentech, Takeda, Amgen, and Icerate for their contribution to this historic online workshop premiere. Now, this is our pre-event formal discussion about cancer in African Americans and COVID-19. But first, we have some rules for the pre-event. You're going to be mostly muted unless the host or facilitator unmutes you. You're going to be called on. Please try to keep the background noises to a minimum. No background noises at all. Type your questions in the chat and the facilitator will identify you and answer the questions. Chat on the mobile phones is the pull-down menu with the 3 dots that say More, where you can raise your hand live or virtually raise your hand using the More pull-down. Now, before we start, I want to introduce Robin Kelly. She's a technical support consultant with 50 Hoops. Are you there, Robin?
She's on.
Okay. Our theme for this series is Cancer in African Americans, Navigating the Corona Zone. Again, this is our pre-event Q&A segment. So I'm going to turn this over to Dr. Doris Brown, who is president and CEO of Brown and Associates, and also the past president of the National Medical Association. Please welcome Dr. Doris Brown.
Hello, everyone, and welcome to the pre-event. As Ed has said, I'm Dr. Doris Brown. I'm a medical oncologist in addition to other things, and I want to just welcome you to this pre-event. Again, this is about cancer in the African American population as well as COVID-19. So just to give you a little quick 1-minute summary, we'd like to talk about and focus on some of the most common cancers, and you will hear our speakers giving you information. But you need to know that lung cancer is the #1 cancer in both male and female African Americans. Primarily, we know the highest risk factor for lung cancer, of course, is smoking. And then there are some other risk factors in terms of our environmental exposures. As the second leading cancer in African American women, it's breast cancer, and for men, it's prostate cancer. And then we'll go on to colorectal cancer. And of course, you will hear about these cancers. But I want to also give you some information about COVID-19, just a summary, because that's important for what's going on today. And of course, we know that in the United States, we have over 2 million, nearly 500,000 cases. And of course, the deaths are reaching almost 150,000. And I will just point out a couple of states that have really seen an increase in the number of cases just recently. The state of Texas is going overwhelmingly crazy. They have had more than 5,000 cases in a day in the past couple of days. And that is because we have forgotten how to be protective in terms of this. And I'm going to give you some of the recommended changes. Florida is another state that is seeing a surge. We have to be able to take care of ourselves. And that means wearing a mask, washing your hands, maintaining that 6-foot distance. And again, if you don't need to go out, don't go out. It's really too early to turn back things. And I know we all want to get out because it's summer. We want to go to the beach. We want to do those shopping. But please, wear your mask. We want to go to church. And it's important, if you're going to church, make sure your church has been disinfected. You still want to maintain that distance, so don't crowd in and all sit on the same pew. You may have to give up that seat that was famously yours in the past because you have to maintain distance. Most importantly, and of course, we have always done this, wash our hands. We know that the mortality rate, the death rate is so much higher in us. Yes, we have pre-existing conditions, but we have the opportunity to take charge of our health and maintain a healthier lifestyle, participating, arming ourselves with information. And that's what this next couple of days are all about, getting the information that's going to keep us alive, healthy in the future. Thank you. I'll turn this back over to Ed.
Open for Q&A.
We will take questions, I should say, a little later on after our speakers have completed their presentation. We have the chat box for you to put some questions in, but we will also allow you to verbally state your questions as long as it's a question and it's not 5 minutes long. It has to be a short question. We can take that with you. Raise your hand and you'll see under those 3 little dots that say more, there's a raise your hand. When you raise your hand, I will recognize you and allow you to state your question. If it gets into 5 minutes, we'll cut you off. But it's all about the family. So thank you very much. Ed, back to you.
Okay.
We'll take Q&A. We'll take we can take Q&A for this segment. It's just basically what are the risks? How are you guys feeling about what we're going through, especially those who have cancers, caretakers? So we did want to take a few questions before 1, and our doctors are not all in yet. So we did want to take a few questions here.
Yes.
So if anybody, Doris, can you unmute people as they say their questions?
Yes, I don't see any hands up.
Raise
Oh,
your
yeah. Oh, I do see one. Let me unmute you. Oops. I am going back to cancel. Okay, Shirley wants to ask a question, but let me go find Shirley's last name, Young. Okay, I see you, Shirley, and I'm trying to unmute you. Perhaps Robin can give me some, there you go. Allow. Unmute. I think you can unmute yourself, Shirley. Sheila.
All right.
There you go.
Can you hear me?
Yes.
Okay, I'll be brief. I am Shirley Walsh Young, and at this very moment, I'm here at MD Anderson Cancer Center in Houston, Texas. And I just want to say, I have been just showered with so many blessings since I've been here. Everything I could have imagined I would have needed in this task that I'm facing now. Last Tuesday, I had a left mastectomy, something I never thought would have happened to me. I had not met anyone really. If they had one, they never mentioned it to me. So what I have learned from this situation, I'll be 77 next month, that I will share all that I have learned through this experience. I've not been able to talk with anyone that has had a mastectomy need to share it with me, but I know what I must do when I go back to Memphis, Tennessee, is to share my experience and educate and motivate all that I can. Thank you.
Okay, thank you so much, Shirley. Well, you are not alone in having had a mastectomy. Hundreds of thousands of women have had mastectomy. Some of us don't like to talk about it. And I see Sheila raising her hand. She's had one. 3 people in my family have had them, and a whole ton of people. You're not alone, and there's support groups that's out there to help you. We'll be happy to take some other questions. Let's see what's in the chat box. Don't see another question. Is anyone else raising their hand? Yes, Gloria. I think you can unmute yourself, Gloria. Let's see if I can get to Gloria.
This Gloria doesn't have a question.
Okay, Gloria Smith, question.
Smith.
You had a
yes,
statement?
I do. Yes, it's just a brief question. Okay. There was something mentioned a couple of months ago about people that are carriers of sickle cell trait, not the disease. I'm a carrier.
Okay.
Is there any data that supports a rise in any cases that are positive for African Americans that have sickle cell traits? I know that this is new and everything, but I was just concerned as a carrier.
Are you saying, is there a rise in the COVID-19 cases, or is there a rise?
I'm sorry. Yes, I wasn't clear. I'm sorry. Yes, that's what I meant.
I just wanted to clarify. There has not been any data to show that there is a rise in COVID-19 in sickle cell carriers. Again, we are at risk for COVID-19 because we come in contact with other people, and many of us have other chronic diseases like heart disease and diabetes and cancer. And if your immune system is compromised in a way, you may be at increased risk. And so again, that's what you want to look out for. Making sure that you're wearing your mask, because the disease is spread primarily through droplets in the air. And when we're going to places to get our hair done because we want to look good, you're spreading that in the air. Be careful with that. Making sure we wash our hands and wash them for 20 seconds. You got to do that. Sing 5 happy birthdays or 5 Mississippis to make sure you get a good 20 seconds washing with soap and water. Then you would, importantly, to dry your hands off with a disposable towel and throw it away. There's been some controversy about using those air things where you stick your hand in. It's good for the environment because it saves on paper, but it may not be good because the air may be dispersing those viral particles in the air to a greater extent.
All right, thank you.
Big question. Okay, other questions? Let's see. There is Irene wants to tell us about a COVID-19 study. Go ahead, Irene. Let's see. Are you unmuted? You can unmute yourself. I'm trying to find Irene.
Yep, I got unmuted. Can you see me or can you hear me? Okay.
I can hear you. Yes.
Okay. Hi, everyone. And thank you again for having me join the group. I just wanted to let people know about the COVID study because we will be opening it soon. I can introduce myself. I'm a physician at Dana-Farber, and we work on specifically on multiple myeloma. And as you know, myeloma is a disease that affects African Americans more than 3 times more than the Caucasians. So we want to make sure we get to know about it. And one of the studies where we opened recently is something called PROMISE study, where we look for it in the African American population because we know myeloma is common, so we're trying to find it. And for those people on the PROMISE study, we will be screening for COVID-19, for the antibody. So if people are interested in it, they can look for it too, because that's important.
Yes, we will have other programs, and we would like for you to coordinate that through the Sanders, because they have a multiple myeloma program. And we certainly thank you for being on the call today and mentioning that. Yes. Okay. I don't see other questions or hands up. Okay, I'm going to turn this. The other important thing is that throughout the discussion, we will be asking you to answer a few questions in short polls. Please do that. And then we also will have little prizes. I will just pick at random and we will notify you. You may get an e-card or you may get a gift basket. And so you will have to put in your information and you'll see this on the screen in a moment that we'll put up how you put your information so that you might get your e-card and your gifts. Back to you, Ed. I keep hearing clicks. You're muted. You're muted, Ed.
There we go. You have to do this. Okay, go ahead.
Well, we want to certainly thank Dr. Brown for that. And we also want to thank you for joining the 50 Hoops in our premier conferences and workshops for June of 2020. Now, Pat and I have worked with many of you over the past 2 decades to educate African Americans about cancer and other diseases that affect our communities. We're pleased that we now have a venue on Zoom to reach not only one city at a time, but across the nation to all the cities we've worked with over the years. I want to take a moment to highlight some of the types of participants we have today. I'm going to recognize all of you, patients, caretakers and their families, physicians, medical partners, ministers and health ministries, community stakeholders and leaders, 50 Hoops board members, Hall of Fame honorees, network coordinators, staff, and friends. And I want to thank all of you for your continued support of 50 Hoops outreach to educate African Americans and the underserved about diseases that affect them. Last, I want to thank our pre-event special guest and workshop facilitator, Dr. Doris Brown, President of Brown and Associates, and also the past president of the National Medical Association. Now, here's my wife, Pat, to give you the rules of the day.
Hello, guys. This is Pat Sanders, director and co-founder of 50 Hoops. We again want to welcome you to MCCaW. 50 Hoops, this is our 50 Hoops first mobile cancer conference and workshop, and there's a lot to cover today, so I'll be brief. Dr. Kelly, if you can put the rules in chat as we go along. First, this is not a webinar. This is a workshop, but it's more like a family reunion with speakers. It's not going to be perfect. Some of us are doing this for the first time. It's going to be rough edges, but it's going to be fun. If you guys can just overlook some of the noises. Most of us have not even done this before. So this is what we're getting ready on our training wheels. We're getting ready to make this work. Now, all of our doctors are not present yet.
So we're going to just continue on. They will be getting a very brief presentation, and you will have a time to do questions and answers directly related to your concerns about cancer. Now remember, cancer is the topic, and the theme is navigating the corona zone. Now, how did we come up with that? Our 9-year-old grandson, Micah, came up to his father, who is with us and who is a cancer patient. And when he was about to venture out of the house, he said, "Daddy, be careful, you're going into the corona zone." So that's how we came up with the name Navigating the Corona Zone. Now, as Ed and Dr. Brown has said, let's turn on our chat and feel free to make comments and ask questions of things related to African Americans with cancer, African Americans with the coronavirus. And for those joining by mobile, I want you to look at the bottom of the screen. There will be 3 little dots that are a pull down menu. It says More, and you can pull down, and that's where you will enter your chat. You can also clap, and you can also do a thumbs up on that. Now use your chat to ask questions. Just type the quick question in during and after the speakers. We may not get to all of them. However, we hope to get to most of them by the end of the workshop. And remember, type your questions into chat. Now, again, we will take live questions just as Dr. Brown has done. Raise your hand live or virtual, and Dr. Brown or Robin or Dr. Kelly will call on you and unmute you. You'll have about 10 to 20 seconds to ask the question. So please be brief and on topic. And please, no real long comments. We're trying to get questions and try to get to as many people as possible. All of you will be muted. If you're not muted, you will all be muted. So keep yourself muted unless you're called upon. We're doing this because of background noises, dogs barking, people talking, machines going on in our homes, which is just natural. And this is literally a call where we're talking in our own living rooms. So we're going to continue that as we go. Now, I want to explain about the gifts and prizes that we talked about. There will be gift bags of 50 Hoops souvenir gifts, several t-shirts, novelties, patient materials, about a $50 value. The gift cards are Visa, that's one of our sponsors, a Visa $50 gift cards, and they will be given away alternately. So you need to listen for your name and what gift you receive, and this will all be at the end of the workshop. We'll randomly select names, so you do need to be present with your name still visible for the drawings. We will mail the gift bags to the winners and email the Visa cards. Now, here's the deal. Be sure we have your name and email. We'll contact you by email to get your address in order to mail the gift bags, or we'll email the gift card link to you no later than the close of the next day. Now, if your name is called for a gift bag or a gift card, you can always send information, your address, to psoc@yahoo.com. If we could get that into the chat, we'll put that as psoc@yahoo.com. That's PEASOC, PEASOC@yahoo.com. And that will be where for people with gift. Now, one more thing about the gift card. We're sponsored by the Visa e-card. So they're not like plastic cards you can take to the store. They can be used online or by phone for mail order purchases. And you will get the instructions that will accompany the e-cards. They will be sent to you. Now, you read more about today's speaker and our network coordinators by going to www.africanamericanhealthmatters.com. And you can look at the bottom of that shifting screen, and anything you need to know about MCCaW, you'll be able to see that. Now I'm looking for our speakers, Dr. Porter, if you could unmute yourself, if you're not. I'm going to ask him to unmute himself. Dr. Screen, I don't see her here. So we will start out with Dr. Porter. Now, before we do, Miss Esther Davis was to be our MC for today. She is national and internationally renowned television host who was to be with us today, and she is heavily involved in the current events. Therefore, she will not be with us as our MC due to her immediate media assignments required with the COVID-19, the protest marches, and all the other important events. And we hope to have her join us in the August-September series. We will miss her wit and humor and her beautiful presence today. So now let's just move on to the workshops. Now,
Dr. Porter needs, there you go.
There he is. Here's what we're going to do. It's been a difficult time for many of us as the world has changed and so many unknown factors impact our lives. MCCaW was designed to reunite 50 Hoops family across the nation in a series of workshops on various cancers that we experience. And making it even more relevant and impactful is the current COVID-19 pandemic, which makes it even more difficult for cancer screening, treatment, and follow-up patients to navigate the corona zone. Now, what is the corona zone? Well, according to Micah, our 9-year-old grandson who created that term, it's any place outside of the safety of your home where there are other people. Simple logic of a child. As African Americans, we often say that God's got this, and he does. And I'm looking for Pastor Lawrence Robinson. If you could unmute yourself, or I'm sorry, Elder Richard Fields, if he's here, Elder Fields. If you could unmute again, we got some rough edges. This is the first time for many of us, but we're hanging in here. This is a family reunion. Is Elder Richard Fields, are you out there? I don't see him on.
Nope.
Okay. Is Pastor Lawrence is supposed to be for tomorrow. I don't see him there either. Okay. Okay. Well, here's what we're doing. We're preacher's kids. So we're going to start out with a brief prayer. Ed, could you say a brief prayer to begin this program for us?
Let us all bow our heads. We want to say thank you, first of all, for bringing all of us together, north, south, east, and west. We appreciate all of you who are participating in this historic event. We could not have done this without all the folks involved. Watch over all of us. Let this be a wonderful, impactful, historic event that everyone can play an important part in. Continue to bless us, what we're doing. To continue to bless each one of us separately as one and as together as a group. Stay with us, pray for us, that this may be a very successful program, and it will move on and make this one of the best of its kind. Thank you again, and God bless.
Okay, now, Dr. Porter, are you there?
Yes.
Okay, why don't you kick us off?
All right. Hello to every one of you. Happy to see you, Mr. and Mrs. Sanders, Dr. Brown, and to all of the other physicians and all of the participants here. I hope that we can do very well to give some good information that we can all use in our communities, wherever we are respectively. And so I will start my talk, if I can get my slides up here. Hold on 1 second. Share my screen. Okay. Let's see. Can you all see my screen?
Yeah, we can see you.
All right. And so I am Jason Porter. I am a medical oncologist here in Memphis, Tennessee, and Germantown, Tennessee, at the West Cancer Center and Research Institute. I'm born and raised in Memphis and did all of my medical training here between Memphis and Nashville at Vanderbilt. And I'm back in Memphis working in my home community, where I hope that I can make a difference for the people here. And now that we got this, this online platform, hopefully for people all over the country and eventually all over the world, because I do believe Mr. and Mrs. Sanders are going global with this. So what we have is multiple myeloma, and I'll just get right into it. The definition of multiple myeloma, it's a cancer that forms in the bones in a type of white blood cell called the plasma cell. And these cells, the plasma cells, are really cells that help you to fight infection. And one of the ways that they do that is by producing a protein called an antibody. And that antibody essentially acts like a flag in your bloodstream. And if you get infections with bacteria or viruses, those flags are placed on those bacteria viruses to let your immune system know, hey, this is a foreign invader, it's an attacker, and it shouldn't be here. It's going to cause trouble if we don't get rid of it. And so after the antibodies or those proteins are attached to those bacteria or viruses, then your immune system can clear those out. And what multiple myeloma does is the plasma cell that's supposed to be producing those proteins or antibodies become cancerous. And so you get one copy of one of those bad cells and it grows up in the bone marrow, takes up all the space. And I always think about it like this, you know, I need an analogy for everything. So if you go to a hotel and you're on vacation and you're ready to have a good time, you set up your room and everything's nice and you're ready to go, and then you hear your neighbors next door and they're keeping up a lot of noise, and it's 7 p.m. and you've been traveling all day and all you want to do is get some rest, but the neighbors just keep going and they party all night. Well, you really don't want to be in that hotel. And that's kind of the way I think about the bone marrow. I think about it like a hotel. And in that bone marrow, you have all of your healthy blood cells growing up. The red blood cells are there, and they give you energy and carry oxygen. The plasma cells and the white blood cells are there. They function as a part of your immune system and keep you healthy from infections and cancer. And then you have other cells growing up there too. Well, if the plasma cells become cancerous, which is what myeloma is, then those other cells can't really hang out there because the cancerous cells are taking up all the good space. And really those cells don't grow up there. And so you basically get bones that are filled with these cancerous cells. And for a lot of patients, before they actually get a diagnosis of myeloma, or before they become symptomatic from the disease, they'll actually have a precursor to myeloma called MGUS. And that's basically a precancerous or pre-myeloma condition that's happening in the bone marrow. And if you have any questions while I'm going, please interrupt. Let us know, let the host know so that we can get the questions. So what are some risk factors for developing multiple myeloma? As you get older, your risk for developing myeloma increases, and most people are diagnosed in their mid-60s. So I have seen some patients diagnosed as early as their late 20s for multiple myeloma. Male sex is also a risk factor, so men are more likely to develop myeloma. The African American, being a Black race, is also an increased risk factor, and I believe that I heard the other doctor mention as high as 3 times it's likely, but some data says 2 to 3 times it's likely to develop multiple myeloma for African Americans. A family history of myeloma increases your risk, and if you have that precursor to myeloma that I mentioned before called MGUS, then you're also at an increased risk of developing myeloma, and patients with MGUS tend to develop myeloma at about 1% per year. So some symptoms of myeloma. Remember we talked about the bones being a place where these, where your healthy blood cells are growing up, and the myeloma is the cancer that's growing in those bones. So you may develop some bone pain. Patients who get myeloma, a lot of times they will present with back pain or a fracture of a bone that shouldn't have otherwise fractured. Maybe you were even sitting down and developed a fracture. So some people with myeloma will, and we call those pathologic fractures. So back pain and fractures is often a presenting symptom. Nausea can also be a symptom. Constipation. Patients who get myeloma usually, because the bones are made of calcium and those bones are being damaged for multiple reasons, calcium will come out of the bones and circulate in the bloodstream. And when the calcium levels reach a certain, when they reach a certain level, the calcium can cause a lot of symptoms. And nausea can be one that can be caused by the calcium, and also constipation. And those calcium ions can change the way your GI tract functions. So where it's supposed to be moving, it may become static and give you the constipation. You can have loss of appetite. You can have confusion or mental fogginess, and all of these can be caused by the calcium as well. Fatigue, whenever I think about cancer, we know that those cells are overgrowing and they're growing at really rapid rates and consuming a lot of energy. So they can give you fatigue by taking away from the energy that your body would have otherwise used for other functions. And because myeloma is a cancer of the immune system's not normal. So people with myeloma can develop frequent infections. And so a lot of times we'll see patients with myeloma come in with recurrent pneumonias over and over, or urinary tract infections, sinus infections. Weight loss as well, which we know is a common symptom of a lot of cancers. So we talked about some of these already, but the complications of myeloma, the frequent infections, because of the bone problems, you will have thinning bones and risk of fractures and breaking or broken bones. Reduced kidney function. Calcium that we talked about before can accumulate in the blood and cause damage to the kidneys. That calcium can also cause severe dehydration, which can damage the kidneys. And the proteins, the cancerous proteins that come from can also be developed in the linings and membranes of the kidney, causing damage to the blood vessels in the kidneys. And so you can see decreased kidney function. And then lastly here, we see anemia. And we talked about how the red blood cells, which are healthy cells, usually growing up in the bone marrow, can be decreased. That's because, again, the myeloma cells are taking up space in the bone. Also because if the kidney function goes down, kidneys are intimately related to your blood counts. And so your kidneys will tell your bone marrow when you need more red blood cells. And so if the kidneys aren't functioning well, you may not get that signal to your bone marrow to make more red blood cells, making the anemia worse. So in order to diagnose myeloma, it usually starts with labs. You may go into your primary care doctor and find that your calcium's elevated or your kidney function's not normal. And that may prompt your primary care doctor to look further into what's causing your abnormalities on your labs. They may check your urine. And if the labs indicate it, they may even do a bone marrow biopsy, which is where a needle is used to go into one of the actual bones so that the doctor can look at the inside of the bones under the microscope to see if we can see an increased number of those plasma cells, which often helps us to make a diagnosis. Imaging tests can be done too, like x-rays. Because this is a cancer of the bones, a lot of times on x-rays we may see that what we call a lytic lesion, which is basically the x-ray has a hole in some of the bones. And so you start to see some of those holes forming in bones, which shouldn't be there. And then we do other scans like MRIs and PET scans, which are just advanced ways of looking at the bones for the doctor. The way we treat it may be a little bit out of scope for my talk, and it may make me go over time. So I'll hold off on giving specifics of the treatment. But I will tell you that we look at the risk of myeloma and we calculate a risk score for patients. And if the risk is high enough, we may recommend doing a bone marrow transplant, which is basically where you get a high dose of chemotherapy after we save some of your stem cells back. We give you a high dose of chemotherapy to kill off the myeloma and then give you back your stem cells, or the cells that help reconstitute your immune system. And then there are other chemotherapy agents that we use frequently in myeloma. Steroids are a very important part of myeloma treatment. And as you can see here, we talked about bone marrow transplant. And then radiation, which is kind of a way to treat the bones directly, can be used to kill off some of the cancer cells if they localize in particular places in the bones, causing pain or other symptoms. We can do external radiation to those, and the plasma cells usually respond really well to that. So as we were talking about the corona zone, I wanted to put this part in here about myeloma. We know that myeloma patients have an abnormal immune system, and in the corona zone where obviously it's an infection, you want your immune system optimal. And for patients who have myeloma without an optimal immune system, may be at increased risk of, number one, contracting the virus, and number two, having complications of the virus. And as we already discussed, African Americans are at an increased risk of multiple myeloma. And we also have heard in social media about the increased risk of death for African Americans with the coronavirus. Part of the problem with multiple myeloma and coronavirus is that the patients with multiple myeloma often have other comorbid conditions or co-occurring chronic illnesses like diabetes, kidney dysfunction, heart dysfunction. And if you take all of those things together with the myeloma and add the coronavirus to it, it's obviously a recipe for a potential disaster for patients who have myeloma if they contract the coronavirus. So I think that's what I have so far.
That's wonderful.
Thank you so much. Okay, well, Pat.
Okay, well, thank you so much, Dr. Porter. Before we open for questions and answers, Dr. Thomas Palasic, professor, prostate cancer researcher at Duke Cancer Institute in Durham. Dr. Palasic, are you there?
Yes.
All right, it's yours.
Hello, everybody. I've been asked to speak about prostate cancer and prostate cancer screening. Are you able to pull up the slides?
Let's see if we have them here. Why don't you continue to talk? We're going to get them. We'll try to get them for you.
So prostate cancer is the most common cancer in men next to skin cancer. And it's the second most common cause of cancer-related death. So it's a very common cancer that affects men, anywhere from 1 in 6 to 1 in 9 men. Now, African-American men have twice the chance of being diagnosed with cancer and up to 2.5 times the chance of dying from it. So it's a very serious disease that is should be taken noteworthy. The prostate is a gland that is located just below the bladder. So it runs when you urinate, the urine goes through the prostate. And when you're younger, it's a very important gland because its function is infertility, making babies. But as one gets older, it doesn't really serve a very useful purpose after a while. It can cause some problems. Most men develop enlarged prostate. So they have trouble urinating, either the stream slows down or they're going more at night, or the prostate can develop infections, what's known as prostatitis, or what I'm going to talk about in brief is prostate cancer. So again, as men age, the prostate tends to become more problematic than helpful. So as you can see here, this is the bladder in the middle, and then you can see the prostate gland with the urethra or the tube, the urination tube running through the prostate. So again, we need to take this seriously. So what we've done at Duke is build a prostate cancer screening algorithm. Now, to bring you back a few years, back in 2012, the government said that we should not be screening any man for prostate cancer. And I think when that advice came out, a lot of the internists and family practitioners stopped checking for prostate cancer. And the way you screen for it is with both a PSA level, which is a blood test, and the finger exam, as men like to call it, the finger wave. I think what's happened is we realized that that wasn't sound advice because that advice did not take into account risk. There are certain men who have family histories of prostate cancer, and then there are certain ethnicities such as Ashkenazi Jews or African Americans who are at higher risk. So we did back in 2013 at the Duke Cancer Center, was we put together our own algorithm, and you can see here, this is just one of the algorithms. It starts with informed decision-making, and for men in their 40s, right? So you could start screening in your 40s, particularly if you're African-American. If you can go back one. Yeah, particularly if you're African-American, because what you can tell in your 40s is what is your risk for developing prostate cancer later in life. We know that that age, your PSA should be low, very low. See in the bottom green rectangle, it should be less than 1.5. There's no reason for your PSA to be any higher at that age because you don't have an enlarged prostate. So really the best time to start screening is when you're very young, when the PSA should be very low. And if it's any higher than that, and you can see the top square here, especially over 3, that means that you're probably going to be at risk at some point down the road in your life of developing prostate cancer. I just wanted to point out a few different tests that we use. Over here you can see the most common one is the PSA. It's a blood test. And then up here you see PHI. PHI is a test that includes PSA and what's called percent-free PSA and a couple other variables which one can use to determine if a man is at risk for prostate cancer. Next slide, please. So Pat asked me to speak about a newer test. This is a very good test. This is the OPCO 4K test. Now, these tests get a little more expensive because they're more specific. And this test will tell a man their risk of developing a high-grade cancer. So not just prostate cancer, but a higher grade that one would need to be aware of and treat if found to have it. So what we did at Duke and across the VA, the Veterans Association in the country, is we looked at this test. And I just wanted to take a moment and say, a lot of the problems we have with screening is that the screening studies come from particularly Europe, and they're done in Caucasian men. So we do know that some of these tests can vary depending on racial group, particularly African Americans. So it's hard to look at some of these values which we say are normal or abnormal when they're based on Caucasians. So what we did is we looked at an African American population based on what I think is one of the best blood tests right now, the OPCO 4K, across 8 VA centers in the country. And you can see we published this paper here, Multi-Institutional Prospective Trial. And basically, what this showed is that the 4K score accurately predicted aggressive prostate cancer, was better than PSA, and it didn't really pertain to any particular racial group, which I think is great news. And I just want you to be aware of that. Okay, next slide, please. I wanted to leave with a message of hope because, what do you do if you were found to have prostate cancer? So the first thing I would say is the way prostate cancer is diagnosed is through a needle biopsy. And then once you get diagnosed, we determine, how aggressive it is and things like that, and then recommend different treatments. And as you probably are aware, there's been a lot in the literature and a lot of talk that African-American race tends to have more frequent cancer and a higher mortality due to prostate cancer. So I wanted you to be aware of, this is a study that came out in JAMA Oncology last year. I think it's a very important study. And what they did is they look at pooled data from 3 large studies. One study was from SEER, which is a large group of data that's in the government system. And then they looked at the VA population. And finally, they looked at a number of men who were treated with radiation therapy trials. And after adjusting for demographic and socioeconomics and treatment choice, I think this is a very important point, that Black race was not associated with poorer prostate cancer specific mortality. Now, what was interesting was that the other cause mortality was actually higher in African Americans. And that's things like heart disease, stroke, diabetes, things like that. So I think the bottom line, there's a couple take-home points from this. So number one, if you screen and come in early and you're treated, I think, you know, you should expect the same kind of good results like anyone else. And second point is that, you know, you have to take care of your health, because you can see in this study that the overall mortality was higher, not due to prostate cancer, but other causes. So in terms of health equality, if a man is diagnosed early and gets an equal treatment, we should expect similar survival outcomes. And finally, this is another study we did at Duke. This is a study on cryotherapy. The picture that you see there are a number of needles going into the prostate, and each of those needles is forming an ice ball. You can see multiple ice balls, multiple needles, basically freezing the prostate. And this is a minimally invasive treatment that some men like. It's outpatient, it's quick, and you can repeat it if you need to. But it's a very physical treatment. In other words, these ice, they grow, they expand, they disrupt the cells, they get really cold temperatures and they freeze. And there's no reason to think that one race would have a better outcome than another, because this is a very physical process. So what we did is we did a matched pair analysis of 300 men who were treated with prostate cryotherapy. And we matched tumor characteristics, and we showed similar outcomes. So again, it's another point with treatments that if you come in early and you detect the tumor at an early stage, that these treatment options should do the trick and cure the cancer. I want to thank you for your time.
Okay, thank you.
Thank you. Let's see. I don't know if our next speaker is here, but we can have a couple of questions. I don't see Dr. Screen. Let me just check again to make sure.
Hello.
Yes.
This is Dr. Britt.
Yes, Dr. Britt.
Yeah, I just wanted the physician from Duke to mention that the rate of rise of the PSA may be just as significant as the absolute number. If you come in at time 0 with a normal PSA of 0.5 or 1, at time 0, and then 6 months later, it's all the way up to 2 or maybe 2.5, even though that's within the normal range, because it has increased so fast, so significantly, you might want to take a closer look at that particular patient. So the rate of rise may be just as important as the absolute number.
Dr. Pulaski?
I think Dr. Britt raises a very good point. You know, this PSA test, you can do a lot of things with it. So one is you can look at the absolute number, which we talked about. Second, as Dr. Britt mentioned, you can look at the rate of rise or rate of change over time. The other thing that you can do with it is if you know the size of your prostate, and men who've had a biopsy before, you know, we typically measure the prostate and I tell them what their size is. You can then compare the PSA based to the size, and you get what's called PSA density. So all these tests become more specific for prostate cancer if you have this other information, either rate of rise or rate of change or PSA density. So there's a lot of different ways you can use PSA, and I also told you about those other 2 blood tests, the 4K score and the PHI. They all have PSA built into them as well, but there's different ways of looking at the PSA.
One other question for Dr. Pulaski. In reference to the controversy around age of screening for prostate cancer, particularly for African Americans, can you just speak to that? And the second part of the question. In reference to the study that you mentioned using SEER data and VA, what's the age range of the participants and how many African Americans were in those studies? Thank you.
Yeah, that's a great question. I'd have to look back at those studies to see. I would suspect that it's a low number of African Americans. And this is a great point because I'd like to put a plug in for participation in clinical trials. It's really important to do this. And part of what I was quoting in that last study, they looked at radiation trials. So that's all men undergoing clinical trials. Now, in reference to age. So remember I told you back in 2012, the government said, don't screen any man, doesn't matter race, risk, just don't screen. So now we screen between 50, 55 to 69. But if you have a risk, meaning if you're African American or if you have a positive family history, we start at age 45. Personally, I would start at age 40. I think, it's really important. You don't need to do this every year, but a man has to get a baseline PSA in their 40s. They have to have something to compare to. And as I mentioned before, you can see if it's less than 1.5, you're good. If it's over 1.5 in your 40s, you got to really start monitoring it. And I just want to make one other point when to stop PSA screening. So again, most societies will say stop at age 69, but men are living longer. And in order to benefit from treatment, you have to have a 10-year life expectancy. So, if you're 75 and you have 15 years to go, I think it's reasonable. And in our Cancer Institute, we'll screen healthy men to age 75.
Thank you. There was one other question. What do you feel about community-based screening programs?
Well, I think it's excellent. I've been running the screening clinic at Duke and the Lincoln Clinic for the past 20 years. This year, we're taking a break because of COVID. But I think in general, it's a great program. Now, I just will make one other point. We tend to see the same men year after year. So I think the people who get the message, they come in and they get screened time and time again. But what we really want to do is we want to see the new men, the men who haven't been screened. So we need to do a better job getting the message out for the community screening programs.
Okay. Thank you. There's a question from Mr. Patterson. Can you unmute yourself?
Yes, I wrote this in chat. Is there a relationship between early diagnosis and a prostatectomy and a shorter mortality rate over long?
That's a great question. My response would be if you have a prostatectomy, then you're going to know the pathology. You're going to know exactly how aggressive the cancer is, where it's located, and then with that information, I think you can answer the second part of that question. So it's really not so much based on surgery, but what the pathology was, the biology of the cancer that was removed.
Thank you.
Okay. I have a question for Dr. Porter. Can you speak about smoldering myeloma, or it's sort of a pre-diagnosis, and I don't want to get too medical, but wanting to have a comment for those that it's not yet myeloma, but it might soon become.
Right. So we mentioned, and not to get too technical, MGUS, and then there's smoldering myeloma. All of these diagnoses kind of depend on how many of those bad plasma cells you have growing in the bone marrow, and whether or not you have any clinical complications from those cells, like kidney disease or bad anemias where your red blood cell count may get too low or your other blood cells may be affected. And then whether or not you're having some other complications of myeloma, which can be numbness or tingling in your hands or feet. This is called neuropathy, and you hear about it in diabetes, but it can also happen in myeloma too. So for patients who have some of those clinical symptoms or syndromes, and they may not have quite the number of plasma cells that we use to make a diagnosis of myeloma, then, you know, it's basically like a rainbow or spectrum of diseases that go all the way from MGUS, which is just having a few additional kind of plasma cells in the bone marrow that are all one copy of each other, but not enough to reach that diagnosis of myeloma, all the way to having full-blown myeloma, where you have a certain number of plasma cells that are cancerous in the bone marrow, plus some of those complications that we mentioned. So the patients who have MGUS, usually the risk of them progressing to myeloma in 1 year is about 1%.
Thank you. There was a comment that Mr. Moore, that's on the chat, stated that he's a good example of an early case of prostate cancer, age 47, and having a PSA of 3.7. So that's really good. Had the screening and early detection. I'd like to call out our first winners. Allie Higgins, please put your name in the box, and that's going to be for our gift bag. Allie Higgins.
Yay.
Randomly selected. Let's give her a virtual clap. Thank you very much. Okay, let me see if there are other questions. Okay. Terry Gray indicated that the kidney function and anemia symptoms are flags for patients being referred for dialysis. Would you like to comment on that, Dr. Porter?
For sure. So one thing that I know and that I've experienced with some of my myeloma patients in the past is that you can get referred for dialysis. Most times, the kidney doctors or nephrologists will actually do some of the workup that may lead you to a diagnosis. I had one with her just yesterday. And so if the nephrologist or kidney doctor diagnoses you with myeloma, a lot of time, well, not, there is a good chance that starting therapy for myeloma, even if you're on dialysis at that time for myeloma, I think they're calling on me on this thing. I have to go, okay. Many times you will have improvement in your kidney function where you don't have to stay on dialysis. So I try to encourage some of my patients who are sometimes hesitant about doing treatment for the myeloma or any chemotherapy-based regimens or treatments. I try to encourage them that if you treat the myeloma, your kidney function could certainly improve, and you could even, and I've had some patients go on short-term dialysis, be able to come off of dialysis after their myeloma was treated.
Thank you. And for our e-card winner, Cynthia Gibson. Cynthia Gibson, please make sure you put in your information in the psoc@yahoo.com. Did I get that correct?
Yeah.
Okay. All right. Well, Pat, while we are waiting, let's see if are there other questions. Anyone want to raise their hand for another question? Did I miss anyone?
I wanted to stop and recognize Mary Jerome. She's with the Multiple Myeloma Research Foundation. We have worked together. Hi, Mary. We worked together for 2 years. She is my sister from another mother, and I love her dearly. Thank you so much, Mary, for joining us today.
Oh, certainly my pleasure, Pat. I'm really happy to be here, and I'm happy to see everybody and listen to all this really valuable information. It's great to be here. Good to see you again, Dr. Porter, and listen to your presentation on myeloma, and you as well, Irene. So great to see multiple myeloma represented. Thank you.
Gotcha. Thank you so much, Mary.
Yes. Did I miss any more hands?
I had a question.
I think I saw, Robin, did you have your hand up? Nope, okay. Go right ahead before I ask another question.
Robin?
She did not have her hand up, she said.
Nope, I'm just glad to be here.
I had a question. Cancer hits all of our families. My son is recovering from throat and lymphoma, and he's living with us now with his 9-year-old Micah, who is very verbal. And for Dr. Pulasic, is he still on?
Yes.
Okay. Surprisingly, he had a PSA of 11.6. They went through and did the MRI, and then they did the biopsy. I think they took like 24 samples. And the good news, they called us back and said he has no prostate cancer. He has no enlarged cancer. Thank you, God. And I was wondering, what do you think could be the contributing factor of a, I guess you call that a false positive or something? How can that be? He's age 51. Dr. Pulaski still around?
I think he's on mute.
Yes, he's on mute. You're on mute, Dr.
Oh,
I'm ready.
There
I'm
you
ready.
go. Yeah, okay.
So there's only probably one thing that would cause that, and that's inflammation or infection. You know, at that age, you probably haven't lived long enough to develop a large prostate, but if an MRI has been done, you can still glean some information. So what I would do, they should give you the size of the prostate on the MRI.
Mm-hmm.
I would take the PSA level and divide it by the size, and the density should be less than 0.15 to be normal. If it's higher, then you have to keep your suspicion up. Second, did the MRI show any lesions, or was it normal?
It was normal, yeah.
That's great. We have the technology now, so if you see a lesion on the MRI and the biopsy's negative, right, which you could say that's a false positive, we have the technology now, we can what's called reverse fuse it. So we could send that negative biopsy back to radiology and say, look, we just did this biopsy, what happened? And they can pull up the needle tracks and say, you know, you missed, that's one possible scenario. Or they could say, well, maybe we overread this as radiologists, maybe this wasn't cancer, maybe it was inflammation or something else. So again, it's more of a process. You can go back to the MRI and try to get greater understanding.
Thank you.
I have a question, Dr. Pulaski. How important and how often does the Gleason score come into play?
Very important. So what we do now is the Gleason 6s are now considered grade group 1s. We've kind of renumbered them because sometimes people they don't understand why the least aggressive starts with a 6 out of 10. It doesn't sound right? So we call that now 1. But if it's a low grade 1, a Gleason 6, we tend to observe those. The 8s, 9s, and 10s are more aggressive, and those should be treated. And the 7s are kind of in between. Most men decide to get treatment with 7s.
Okay. There was a question about how do you get the gifts? You don't sign up for the gifts. It's just randomly selected.
Let's keep
pull
coming.
a name out of the hat.
A lot of stuff back here.
Yes. I want to say Gary White as the other person will get an e-card. Gary White. Make sure you go to put your information in at yahoo.com.
All
Thank you very much. Thank you very much.
Okay. And for the gift bag, Michelle Roundtree.
All right.
And I think we had some polls. I don't know if we want to try and do a poll right now.
Yep, let's do it.
Robin, are you on? I know Robin has had some difficulty going in and out. Yes. Okay, you'll see this on your screen. If you're on video, please answer the question and we'll give you 20 seconds.
And you can keep calling names. We got a lot.
Okay, on a scale of, I'll read the question for those on the phone. On a scale of 1 to 10, how healthy do you consider yourself? 1 being not at all healthy, and 10 being in excellent health. Okay.
Well, no,
What do you want?
you put.
Okay, we ask you again to please mute yourself if you're not speaking. Okay. Kim Osundina. I hope I pronounced that correctly. Kimmy Osundina, you're getting a gift bag.
Great. Osundina. We'll get it. Was it Tim or Kim?
Kimmy, K-E-M-I. Kimmy
Hey, how's it
Osundina.
going?
Oh, Kimmy. Yeah. Hi. Yeah.
I'm good. I'm good. I'm just working.
Okay.
Yeah. Please put your
No,
information.
you know what? I'm glad you called because it's kind of, you know what? I needed to take a little break anyway, and it's kind of
Frederick,
been one of those weeks.
Frederick, could you mute yourself?
But how are you doing?
Frederick.
We're hearing somebody talk.
Yeah, I gotta find it.
Okay. Please mute yourself.
We got
Or
it.
we can mute,
There's
we'll
another
mute all.
poll. Yeah.
Okay. And for the e-card, let's go with Norma Jean Lewis.
Good afternoon, everybody. This is Tanya Usher. Hi.
Hi.
Hi. Hi. I'm Ed's daughter. Hi, Pat.
Okay.
My stepmom.
Okay.
I just wanted to.
Question?
I just wanted to say hi to everybody, but I also wanted to say I'm doing the poll, and one of the questions on there, it asks about, have you had any of the following? And if you don't answer the question, then I'm not able to hit submit at the bottom. It won't let me submit.
Okay, you might be part of the host team and you cannot participate in the.
Oh.
No, I'm having.
Hi, it's Dr.
This
Britt.
is Erin. I'm having the same problem.
Yeah.
Oh, okay.
This is Emmett, and I'm having the same problem.
Okay, well, we will have to work on the polls.
We all are. We all are having that problem. Even the pollers, even the hosts are having a problem. It's okay. You can see the question, and we can we'll do this. Yeah, in the chat.
Hello. The other issue.
Yeah, I need an NA for number 2.
Yes, that you have any of these problems, and I haven't had any of them. There was no answer. Okay.
Congratulations on that. Thank you.
Okay, that's wonderful.
That's right.
Great. Okay.
Oh, you need to be able to say no that you had none of them. You had
okay.
5 or 6, and you had to select one of them. I had none of them. So what do you do?
Okay, we will check that. We'll make sure that the question is corrected to give none of the above.
There you go.
That'll probably be the reason why you don't get any poll results, because we can't click submit.
Ah, okay. Thank you.
Let's try another poll and see how this works. Let's go to another one and see if this works.
Okay, and Dr. Porter, did you have a question?
I had a question.
Comment?
I had a question from one of the participants, and they asked, is frequent blood transfusion a way to prolong life for patients with multiple myeloma, getting a series of healthy blood transfusions? And I want to let Dr. Gabriel reply to that, if that's okay.
Sure. Thank you, Jason. I'm happy to help with that. So blood transfusions can help you just improve the anemia, but they don't really fix the problem. It's sort of just covering the problem instead of actually fixing it. But the treatment itself should help. And if you need blood transfusions while you're on treatment, then that can help you a lot. So that's the most important difference.
Okay.
Okay. I think there was a question from Sheila Patterson.
Well, this is a quick one. So it's 2 of us. So I guess I cannot answer. I'm letting my husband. We can't answer both because he's had prostate. I had breast. It won't take both.
Okay. Thank you.
Well, thank you for that. That's good to know that we have cancer survivors here. Thank you. Yeah.
Yes, yes. Okay. We're working on the poll to make sure that we get the questions in. Let's go with Wanda Jackson as our next recipient. Let's see. I think I just had a gift basket going to Norma Lewis, I guess, for Wanda. This is an e-card.
One more e-card.
Okay. How about Deborah Coleman for a gift bag? Make sure you put your information in psoc@yahoo.com.
Poll in progress.
Okay. Do we have another poll coming?
Yeah, we're going to fix all these glitches in the polls. I'm glad to hear the feedback.
Okay.
This is new to us, and we're going to get better with this, but we've had some good information.
Great.
One more.
Let's see, for a gift bag, Johnny Suds. Did I get that correctly?
Yay.
Okay.
From Mount Airy.
Yes, yes. And Amazon, it's Harvey. I don't know if that's the correct name or that's the name you're under, Hervey. Amazon Hervey?
Mm-hmm.
Yes.
She's good.
That's for a gift bag. Okay. Jennifer Socket. Excuse me, Jamila. Jamila, did I get that correct, Jamila? Stockett.
Yeah, that's her.
Okay. Great. Is that the last of our gift cards?
Last one, yes.
Okay. Jamila Stockett.
4 more gift bags.
Okay. Oh, well, I'll have to randomly just pull somebody.
Yeah.
How about, let's see, I did Norma Jean.
I'm here.
Okay, you had received let's see, you had an e-card, I believe. Did you put your information in?
Yes, ma'am.
Okay, good. Timothy Upshaw, are you part of the team? Can you get a gift bag?
Yeah, he can get one.
Okay, Timothy Upshaw gets a gift bag.
3 more left.
And Wolfram Battler?
Yes. Yes.
Yes.
True that.
Great. Let's see, where are we now, Ed? How many more? Tanya Upshaw?
Tanya Usher. She has a question for the doctors.
Okay, and Tanya Usher gets a gift bag.
Okay.
Woohoo! Thanks.
Okay, let's see, what's your question?
My question is, my aunt on my mother's side just got recently diagnosed with a cancer called estrogen receptor positive. And my question for the doctors on the line is if anyone is familiar with that and how that works, could it possibly become terminal, or is it something that could definitely be treated, we were told, with just a pill once a day for the rest of her life and not any surgery or chemo or radiation? Are any of the doctors on the line familiar with that type of cancer?
Yes, this is breast cancer that you're speaking about?
Yes. But it also spread to her pancreas.
Oh, wow.
Wow, that's a little, breast cancer can, of course, spread to any place, but that's a little uncommon to go right to the pancreas. I will say that estrogen receptor positive breast cancer, of course, is very treatable. I don't know whether, you didn't mention that she's staged. She needs to have a staging, even though it may be a small lesion. That lesion generally is surgically removed, and then you treat that with, you can take a pill, and I hesitate to say for the rest of her life. Generally, we use a 10-year time period in terms of treating an individual, but again, she needs to have her consultation with the surgical oncologist and the medical oncologist and the radiation oncologist, and of course, come up with a regimen, what is best for her. Her age would have to be considered, her performance status, And again, you did not mention whether nodes were involved or not involved. So
Yes.
all of that has to be considered. And then you come up with the best regimen for her.
It was stage
with-
3, and it did spread to her lymph nodes as well.
Okay. So and you didn't tell me how old she was.
She
Over
is 70, she's 73, 72.
The most important thing is that they do not let the 73-year-old as the age, because many times in terms of screening, we get up to 70 or 75 and we stop screening individuals, but we know that people are living longer. And so to say, well, maybe she does not need to have surgery or she does not need to have a lymph node dissection, all of that has to be taken into consideration. I will just say that my mother was diagnosed at 95 and people wanted to say, oh, well, I mean, she's 95, but a viable 95. I insisted she had surgery and she lived until she was 103. She was breast cancer free. So again, be very aggressive in making sure that all of the boxes are checked. And I certainly will have Dr. Palasic and Dr. Porter to chime in because age is just a number these days. And so at 73, she may be as active as a 52. And I don't know what other medical conditions she has, but those all need to be taken into consideration. And even at stage 3, breast cancer is still treatable.
Thank you, Doris.
Yes. Dr. Porter, Dr. Palasic, any comments?
Questions?
Okay. There was a question. Just thanking me. Okay. Don't see more questions.
What?
Is there a verbal question, please? I don't see a
Ernest
hand.
Retlin, did I hear Ernest Retlin?
Yes, you did. I have a question.
Go ahead, Ernest.
Go right ahead.
Yes, my question is for Dr. Porter. Dr. Porter, what's the difference between multiple myeloma and CLL?
Oh, okay. So these are really 2 different cancers, and kind of the way I think of them is like, well, I don't want to, because it's 2020 and in America, things are so racially sensitive right now, but truly, if you think about it, it's almost like 2 different races of people. So you have white blood cells growing in the bone marrow, but if you have the myeloma cells, these are called plasma cells. Think about them as one race of cells. CLL cells are a different race of cells, and they're called lymphocytes. So CLL stands for chronic lymphocytic leukemia. So it's like having 2 different races of white blood cells. They're not the same. They come from different lineages, and so they cause different diseases and different syndromes of diseases. So myeloma, being a disease of the plasma cell, puts you at risk for infections, but so does CLL, because again, this is a white blood cell, so it's a part of the immune system to help fight infections and cancer. But so they essentially are cancer of a different race or lineage of cells from the bone marrow. CLL, usually this is increased white blood cell called lymphocytes circulating in the actual bloodstream. Now you can get those cells collecting in the lymph nodes, and that's a similar disease, but we call it SLL, for small lymphocytic lymphoma. And so this is the same disease, but it's growing in the actual lymph nodes. But the myeloma is definitely, it's a cancer of the plasma cell, so different lineage of white blood cells than the CLL or chronic lymphocytic leukemia. Does that make sense?
Mm-hmm. Yes. Monica James has a question for you, Dr. Porter.
Okay.
Go ahead, Monica. Take yourself off.
Hi, Dr. Porter.
Huh?
Okay, yes. So my dad has multiple myeloma, and he's had like a lot of oral health issues. Like, for example, like he's had like bones sticking up from his gums, where they had to like saw it down or like remove it, and it's happened multiple times. So is that normal, or is that a result of the?
So I can think of a couple of different scenarios that could lead to this problem. So the bone marrows are responsible for making your blood cells. And if you have myeloma in different portions of your bones, then other parts of your bones may take over the function of creating those blood cells. So if you have, like your long bones are full of disease, then your gums, your jaws are big bones, you know, your maxilla and mandible, these are big bones. And so you can start having overgrowth of red blood cells in here, in these bones, so, and in your gums where your other bones are trying to compensate for where the long bones that usually produce cells aren't working. You can also get that in the bones of the skull. And then you can also have myeloma growing in the bones as well. So if you have myeloma growing in these bones, then those may overgrow. We call a collection of myeloma cells in one particular bone a plasmacytoma, which means group of those plasma cells. And so you can have those in the actual, in the mandible and the maxilla, the bones in your face. And if so, then you could see those overgrown. So that could be a second scenario. So number one, maybe these bones are trying to compensate and make more red or white blood cells. Number two, you actually have myeloma growing in those bones. And then number three, at risk for infection. So these could actually be abscesses or recurrent infections there as well. And I think Dr. Gabriel has something she can add.
Yeah, no, this is absolutely correct. I would just be careful that if he's taking a bone strengthener, something called Zometa or pamidronate, that's a complication of that drug. It can actually make them have something called osteonecrosis of the jaw. So he should go see his dentist and make sure he's not taking the bone strengthener because that could cause the problem. Absolutely.
Right, I know he's on the bone strengthener, and he's had like abscesses where it's been like very painful. So he's been on antibiotics for a long period of time. And so, but I guess with the antibiotics for a long period use, I'm sure that's not helpful because can't you get resistance to it after a while?
You can develop some resistance to the antibiotics if you've been on them for a long time, but a lot of patients have to be on chronic suppressive antibiotics. So that's a little bit less concerning, but actually if he's having this issue, I agree with Dr. Gabriel that he should be assessed to make sure he's not having actual damage to the bones in his face or in his jaws. And then again, to make sure that there's no actual involvement with the myeloma in those bones as well.
Okay, great. Thank you so much.
Thank you.
Okay. I want to thank everybody. We're getting near our time. There's a mention that Dr. Palasic community screening program is a part of a newsletter that's at Duke. You might check that probably on the Duke website to see that area. Ed, did I have two more names to call or did I get to everyone?
One more gift bag.
Okay. Joy at Tab Alcatel. I don't know if that's your last name, Joy, or is that the system you're on? Please go to psoc@yahoo.com to enter your information. Okay.
Okay.
And I'm going to give it back to, I want to thank everyone. I don't know if there's another. Yes, there's nothing else in the chat box. Thank you all so much for attending, and back to Ed and Pat.
Thank you all. Mary, did you have a question?
Yeah, well, I just wanted to make sure that everyone knew, this is following on the multiple myeloma information that we've been talking about today, but the MMRF is starting a great new initiative for all myeloma patients. It's called our Cure Cloud Registry, and we will be doing genomic sequencing on myeloma patients who join the study free of charge so that we can determine your subtype of myeloma and then maybe help determine what your next treatment will be. And we're working in collaboration with Dr. Gabriel and some of her studies, PCrowd and Promise. So even if you join her studies, then you might automatically be able to join our study. So I would encourage you guys to, keep abreast of what we're doing, go to our website and sign up for emails. We'll keep you abreast of that. But it's really, it's our way of reaching out to our patients and offering them a service they would not normally be able to access. And that's, you know, we're paying for this genomic sequencing for patients to be able to gather more data on multiple myeloma, and that will help us all, you know, find a cure for this disease. So just wanted to put that in there.
Well, you know what we're going to do? We're going to give multiple myeloma, prostate cancer, all of the cancer folks a chance to have virtual exhibits. We didn't start at this time because we didn't have the process in line, but we will have virtual exhibit sponsors. So at the end of our program, Q&A, we will have a 3-minute presentation. You can have your table set up with your materials virtually. You can tell them all about them in the presentation. You can send them links, and we will begin that in August. And I hope that both the Multiple Myeloma Research Foundation will become one of our virtual exhibit sponsors, as well as the PROMISE study, as well as all of the other studies. We hope that you guys will join us in the future, because we definitely want to keep all of our audiences abreast of that. And the small time that you have here is not quite enough, but we appreciate it. Put it in the chat, and we will be talking with you about joining us to have a small presentation in the future.
Okay.
I want to thank all of you for being a part of the first African American Health Matters mobile cancer conferences and workshops. We appreciate all of you for your time. We love you all because we've worked with many of you in the last 2 decades. So please be safe, stay safe. Tomorrow night at 4:30, 5:30 Eastern, 2:30 Pacific, it is going to be all out town hall meeting. We're going to do nothing but Q&A practically after Dr. Ray Page, who was on the U.S. Committee on Cancer and COVID-19, along with Dr. Ahmad Ali, who is with Howard University, and the panel will all be here, and it will be mostly Q&A. So come with your questions ready, and thank you so much for joining us this afternoon.
Thank you. Did you want to have Reverend Square
very much? Yes.
To give a benediction?
Yes, please. Reverend Squire?
Yes, ma'am. Can you hear me?
Yes, we can.
Yes.
Okay. Let's pray. Most gracious Heavenly Father, we thank you for this day. We thank you for this hour. We thank you, Lord, for your people who are reaching out to the community and trying to address the problems that we face. We ask, oh Lord God, that you would continue to bless this effort. Lord, that each and every one of us will take something down from this that will help someone that we know or someone that we don't know. Now, Lord God, we thank you for each and everything that you have done for us. We can't do anything without you. In Jesus' name I pray. Amen.
Amen. Thank you. We always got a lot of preachers in the house. Thank you.
Great job, 50 Hoops from Stradlin.
We love you. It took all of you to make this happen.
Thanks, everyone.
Bless you.
Amen.
Bye-bye.
Amen.
Take care.
Thank you.